Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, Markus at Home welcomes Professor Rukshana Shroff in London, UK, with whom we would like to discuss recommendations on calcium intake in children with chronic kidney disease, based upon a recent European consensus statement published in NDT with Dr. Shroff as senior author, which NDT's editor-in-chief, Dr. Andreas Kronbichler, and I chose as our NDT's pick of the month for Markus at Home. Dear Dr. Shroff, dear Rukshana, thanks so much for being our expert tonight. It's a pleasure to host you.
Thank you very much indeed, Gunnar and Andreas, and thank you, Lars, for being the moderator for this session. It's really a pleasure to be selected among so many excellent papers in NDT for this excellent webcast. Thank you.
Dr. Shroff is a professor of pediatric nephrology at Great Ormond Street Hospital for Children and the Institute of Child Health, London, UK. Her research focuses on bone and cardiovascular disease in childhood CKD. She has served as a member for the KDIGO Executive Committee and works on international guideline committees for KDIGO, NICE, and ESPN. She was the scientific chair for the annual ESPN Congress in 2023 and will co-chair the IPNA Congress in 2025. And as Andreas Kronbichler and I are not pediatricians, we're very happy to have Professor Lars Pape as guest editor. Professor Pape is head of Department of Paediatric Nephrology in the University Hospital of Essen, Germany. So Lars Pape, thanks so much for supporting us tonight. And next week, we are back in adult nephrology as we plan to have part 2 of our conversation on calcium intake, then focusing upon grown-up patients with Peter Evenepoel and Mark Verfleu as our guest. So thanks again, and it's a pleasure to have you tonight.
So thank you again for inviting me, and it's a real pleasure to be here and present to you all. Here are my disclosures. Perhaps what I should say is I'm a pediatric nephrologist, so I'll be focusing very much on the pediatric perspective of this recommendation on calcium intake in children and adults with CKD. You see that the guideline is endorsed by ERA, specifically the ERA UROD group and the Renal Nutrition group, as well as by the European Society for Paediatric Nephrology. Some of the key questions we are going to address is with calcium, how low can you go and how much is too much? Our guidelines are focused very specifically on 3 or 4 areas. These are the recommended calcium intake in healthy children of different ages. How do we determine the calcium intake? And then the third question is the recommended calcium intake per day in children with CKD. So I'm going to show you some information from the guideline, but just before I start that, I want to show you 3 or 4 slides to really focus in on why children are different from adults and why the needs of the growing skeleton are so different. So firstly, we know that there can be too little calcium, which is associated with bone pain, rickets or osteopenia, and fractures. And you see this little boy with severe limb deformities and old fractures and short stature. On the other hand, one can have too much calcium, and too much calcium can result in vascular calcification, like you see in the image here, with all the 3 main coronary vessels calcified. And so we are walking a tightrope and a very fine balance between too little and too much. Now, the calcium requirements of the skeleton change over time. If you look at this graph here, on the x-axis, you see the age from birth to 100 years, and on the y-axis, the bone mass or the total mass of calcium in the skeleton. And the skeleton has only 25 grams of calcium at birth, which then increases to 1.5 kilograms in an adult male. Most of this increase is in the first 2 decades of life, with a very, very rapid accrual of calcium in the skeleton. Thereafter, in men and women at different ages and with physiological processes, the bone starts to demineralize. This information can be looked at in a different way, looking at calcium balance in this table on your right-hand side. So here you see that in infancy and adolescence, which are the periods of most rapid growth, there's a rapid accrual or accumulation of calcium in the bone. This is then much slower in young adults and 0 in mature adults, and then actually negative in the elderly people. Look, the growing bone needs calcium, and it's extremely important to keep this in mind. We know that young children can also have fractures. So looking at this data from CKID, or the chronic kidney disease in children cohort, in over 500 children with mild to moderate CKD, in the majority, or 83% of them, they showed that over a 4-year follow-up, there was a 2 to 3-fold higher fracture risk in boys and girls with CKD compared to their healthy peers. And this increase in the fracture risk was associated with the Tanner staging of puberty, the child's short height, the GFR, walking difficulties, and with perhaps some protective effect from phosphate binders. We see also in another recent study from my group that 58% of children reported bone pain, and 10% had a lifetime fracture, which was a low trauma fracture. And we see that bone pain can be in the lower limbs and back, seen even with mild exercise, and required a regular use of analgesics. So this is a significant morbidity even for young children. We know from bone CT scans, or peripheral quantitative CT scans, that the calcium and the vitamin D levels are directly associated with the cortical bone mineral density. And in fact, when these children are followed up over a year, a decline in cortical bone mineral density is associated with with lower calcium levels. So calcium seems to be protective, especially in the growing bone. Now, looking at bone, and also, sorry, I should add, even 1 standard deviation decrease in the bone mineral density was associated with a 2-fold increase in fracture risk. Looking at the data through a different way, through bone biopsies, we see that even in children with early CKD stages 2, 3, or 4, the bone mineralization is already affected. 29% of children in CKD2 have abnormal bone mineralization, and this increases to as much as 80% in children with CKD4 and 5. And as you will guess now, a low calcium and a high PTH are associated with abnormal bone mineralization. Remember that in CKD stage 2, the PTH levels may not even be raised, and you may not even be concerned with any clinical symptoms, but already demineralization of the skeleton has started. We looked at this process through the calcium isotope technique that we have been developing over the last few years. And in this graph here, you see bone demineralization to the right of the dotted line. And you see that compared to healthy children in the red box on the top of the graph, children with CKD or on dialysis are right at the bottom down here. And in fact, these young children have more severe bone demineralization than even elderly osteoporotic women in the gray bar. So this is really significant and severe skeletal issues. So coming to with this background now, coming to the recommendations we can make, what is our first question in our guideline is, what is the recommended calcium intake in healthy individuals? You will remember this graph I showed you well, and therefore you see at a glance that the calcium requirements vary considerably throughout the lifespan. And the normal ranges have been suggested by several of these international groups. We look at the balance studies and see that infants and young children are in a positive balance, and therefore our recommendation and our evidence point is that the recommended calcium intake for healthy children must be within their age-appropriate normal range. Now, how is this derived? So just to quickly have a glance at this. So the calcium requirements are derived in the healthy population in infants by looking at the amount of calcium absorbed from breast milk in breastfed babies. In children and young adults, a factorial approach is used. This means they literally look at the ins and outs of calcium, look at the bone accretion or need for calcium, and the endogenous losses in urine, feces, and sweat rather, and then the percentage that is absorbed. And in older adults, data has come from balance studies as well as from outcome measures. The balance studies are these pooled analysis of calcium balance studies from men and women, and a lot of extensive work in this by Hunt and Johnson. Also, randomized trials which have looked at the outcomes in bone mineral density on DEXA or actual fracture risks are used for these data. As an example of the factorial approach, you can see here that from the DARC, the German Society, and from the EFSA, the European Food Safety Association, they have used this approach to look at the average calcium accretion, the urinary, fecal, and sweat losses, and then the total calcium need for that patient as the sum of these 4 columns, the percentage of the calcium that's actually absorbed. They use a factor of 30%, and then the average calcium requirement per day is calculated, and you see how it varies across the ages. The EFSA have used a very, very similar process as well. As part of our work, we've used this terminology called the SDI, or the suggested dietary intake. So you see immediately that this is Gaussian distribution, and 97.5% of the population will be within the SDI range. And the SDI is really used because a large number of international bodies have used variable terms like average intake, the recommended dietary allowance, the recommended nutrient intake, etc. So based on this SDI and putting together international data, these are our recommendations for the SDI for calcium for children of different ages. And children who are very young or very short and have very poor growth, we use the height age as an approximation. How do we assess the calcium requirements in clinical practice now? It's a very practical point. And here we suggest that there are 3 different ways to do it. One can use a diet history of a typical 24-hour period, and this helps in a clinic for the dietitian to very rapidly assess the calcium intake. A 3-day prospective diet diary of food intake can be tried when one needs more detailed information. And we actually send out these electronic diaries to families before the clinic, asking them to fill in this data. And an estimate of the total calcium and phosphate intake can be derived from the diet, the nutritional supplements, but not forgetting medications and the dialysate as well. We have done some work through the Pediatric Renal Nutrition Task Force and published detailed assessments of how these data can be obtained, and actually also provided guidelines for the dietitians, as well as patient-relevant documents for children and parents on the practical aspects of managing their calcium requirement. A quick snapshot here is the foods that contributing to calcium intake in healthy people. You see that the largest proportion comes from dairy products, but also some from cereals, as cereal meaning grains as well. The calcium foods that are rich in calcium will depend on the child's age, their food preferences, and national guidelines on food fortification. For example, in the UK, they fortify the flour for bread, and that gives a good source of calcium. We keep in mind that 30% of dietary calcium is absorbed, and the absorption depends on the source and presence of oxalate or phytate, as well as the vitamin D status, of course, and the age of the child. We also know that the foods that are rich in calcium are also rich in phosphate. So if your patient truly follows a strict phosphate control diet, they will become calcium deficient. So you see the very strong correlation in the graph on your left between calcium and phosphate. And here on your right, you see compared to the green bar for healthy children, you see that children with CKD and on dialysis have a substantially lower percentage calcium intake of about 75% of normal from their diet alone. But the addition of medications provides more calcium, and this takes their calcium intake into the normal range, sometimes a little bit also supranormal, but this is the prescribed calcium for these patients in this observational study. So this is the summary slide from our consensus document. Peter Evenepoel will discuss the adult side of it in great detail. But for the pediatric side, the total calcium intake must be age appropriate and in the normal range, keeping in mind the importance of calcium for the bone and not too much to cause vascular calcification. Thank you very much for your attention, and I'm very happy to take questions. Thank you.
Yeah, thank you very much, Rukshana, for this fantastic and very comprehensive overview on calcium intake. I think one point, just to clarify for maybe some adult nephrologists who were listening, it seems on the first view that smaller children obviously need less calcium than older ones, but corrected per body weight, the intake of calcium is much higher for infants than for school-age children, right?
Indeed, indeed. You summarized that absolutely correctly, because infants grow the fastest, and then the second rapid phase of growth is in adolescence. So these are the 2 times in one's life when you need the highest calcium requirement.
When would you really start to get dietary records from the families or children to more or less steer your calcium intake? Do you do that regularly in every CKD2 patient, or do you start with CKD3 or 4 to do that? Because you showed quite convincing data that we maybe should start looking on calcium with CKD2.
You're right, Lars, if we had the resources and hundreds of dietitians, that would be really important and appropriate. Sadly, real life is different from that. So as much as we stress the importance of calcium needs, we're not able to do this in every child. However, I must add that in the infant clinics, or the baby clinic as we call it, it's really important to have a dietitian involved because of all the needs of the growing infant. Not calcium is one important part, but obviously the protein and the energy requirements are also crucial. So our baby clinics always have a dietitian who guides the family. In our regular advanced CKD and dialysis in older children, we as physicians try and provide some advice, with the dietitian then of course helping in more severe, more advanced cases.
Yeah, okay, that's similar like we do it. And I think in infants, it's not so difficult to steer because we have breast milk, we have formula milk, we can mix different and supplements and create the diet for the child as the need is. I was a little bit astonished about you showing, I guess, mainly for older children, that phosphate binders with calcium are an important source of calcium. But in the end, you showed that at least also CKD children need a normal intake of calcium as compared to healthy children. So if we supplement or if we administer calcium phosphate binders, we give, I don't know, 3 times 3 grams of calcium carbonate or acetate, do then those teenagers have to decrease their calcium intake with their normal food?
It's a really important point. So we never ask a patient or a person to decrease their calcium intake. We would rather adjust the binders accordingly. So the patients, especially the teenagers, need to watch their phosphate intake in advanced CKD.
Yeah.
And if they truly watch their phosphate intake, their calcium requirement will be lower. We know that processed foods are so rich in phosphate, and it's so difficult to manage in a teenager. So that immediately becomes an issue. But we would adjust the calcium from medication, largely phosphate binders, and dialysate, and lower these in the first instance rather than ever reducing the calcium intake. Only in very, very rare cases of extreme and persistent hypercalcemia do we have to then deliberately reduce calcium intake and give low calcium diets, but that's extremely rare.
But would you primarily use calcium or phosphate binders with calcium? Or is there maybe a lab value, whatever, that would indicate you to start sevelamer or other calcium-free binders? Or would you primarily use calcium-free binders?
I would primarily use calcium-based binders like calcium carbonate or calcium acetate. This is what is recommended by KDIGO and by NICE, the UK NICE Institute. And my first-line phosphate binder would always be a calcium-based phosphate binder. The only caveat there is if somebody has overt hypercalcemia, then clearly during that period of time, you need to give them a calcium-free binder like sevelamer. In my experience, over time, the use of a calcium-free binder is sometimes needed only for a short period of time. And often you then go on to a mix of the two, a little bit of calcium-based, calcium-free with different foods. And then eventually, hopefully, if they're in good health and growing, they will come back to a calcium-based binder. A key factor here is the growing bone needs calcium. And the word growing can't be stressed more. If it's only a bone that grows, that needs the calcium to mineralize. So in a child with severe growth stunting from genetic causes, from very, very poorly managed CKD, if they're not growing, then they don't need that calcium.
Is there any good way to monitor calcium? How much sense does it make to look for total calcium or ionized calcium in the blood? And are there any target values you would say, or you could recommend?
I think it needs to be age-appropriate target levels for calcium, as also assessing calcium phosphate, alkaline phosphatase, and PTH and vitamin D, and all taken together. So it's really important that you can't just look at one level and not another. Looking at all these markers together and following the serial trends in levels rather than a single level is really important.
Yeah, obviously, but all those, I mean, not PTH, but calcium levels, they should be in age normal range and not in the upper end.
Correct.
To say there's a calcium loss on the lower end or whatever.
Absolutely, in the age-appropriate normal range. Absolutely.
That's the same as it is. Do you think any other way of monitoring, like X-ray of the left hand or even bone density measurements, would you recommend that in routine use to steer your calcium intake somehow, or to see if there's a deficiency, or won't you do that? And
that's a really good point. So we looked at that through a PhD project and saw that comparing the regular serial monitoring of these biomarkers I mentioned versus adding in DEXA, or even adding in peripheral quantitative CT scan, which is a research study really, there was no added value of doing DEXA at all. So really the biochemical monitoring is at present the best monitoring we have. Remember, a radiological change in DEXA will manifest over a long period of time, not in a short or real-time way as the biomarkers do. And therefore, it's only a long-term assessment on the DEXA. Unless there are specific indications, I would not do DEXA. The X-ray of the left hand is really for bone age and not to assess mineralization. So that's really not very helpful.
Yeah, so in a way to summarize, your message is quite easy, which is quite good to know. Try to have a normal calcium intake as for healthy children. Look for normal lab values, more or less, and combine those. And especially in infants and smaller children, really look for the intake and really adopt, not only for calcium, but also for protein, all the other things. And in elder children, try to get them to have a low phosphate diet, and thereby they can also decrease their calcium intake, and you can supplement that with calcium phosphate binders. So at least that's a little bit my summary.
I think that's perfect.
Good and easy measure, because you always look for something that you can really work with in real life and with real non-adherent teenagers. Yeah.
Exactly. I would just add one more sentence to your excellent summary, and that is to say prevention is the key here, rather than let the bone go out of control, let there be severe hyperparathyroidism, and then try and reverse things. So that's really difficult and often not so successful. So wherever possible, prevent the development of severe hyperparathyroidism and control the bone growth in the best possible way. Thank you.
So do we have some questions from the adult nephrologists?
Yes, indeed. So you mentioned bone biopsies, so that hasn't really, has no major value anymore in adult nephrology, I think. When would you suggest that to your patient or to the parents of your patient?
A very good question, Andres. So we would only suggest a bone biopsy if there were very specific bone diseases. So we know that some rare genetic conditions like cystinosis or primary hyperoxaluria are associated with bone involvement. In those cases, one might consider a bone biopsy, not in the routine CKD-MBD situation. Of course, very rarely, if there's just persistent or severe hyperparathyroidism that's unexplained by the biochemistry, or there's an unusual presentation, then we consider it, but not as a routine measure.
You also mentioned calcium balance measurements, so not only intake, but also excretion. So how in practice does that work? Because, we want to understand the practicalities behind that.
Very true. So those calcium balance studies were, in fact, the factorial approach and calcium balance studies I showed you were all done in healthy children of different ages. There are no calcium balance studies in children in terms of formal studies, but because it really requires the child to be almost literally in a metabolic lab to eat a fixed diet and then to collect all the excretion. You need a period of stabilization before you can actually measure and see the changes. So it's not practical at all. We've therefore introduced the concept of calcium isotopes, which are a very sensitive way of determining the bone calcium balance, and it gives a real-time assessment of changes in the bone uptake or leaching out of calcium.
When it comes to bone turnover, that's of course something we also know in the adult space. Are there any experimental biomarkers which might come into clinic, like osteopontin or something like that?
Yeah, that's a good question. Osteopontin, osteocalcin, osteoporphyrin, they've all been around for a long time. None of them have really sort of hit the mark in terms of providing more valuable data than the current range of markers we have. There's a very good study from Peter Evenepoel's group, which has suggested that rather than focusing so much on PTH, where the bone may be hyporesponsive to PTH, in fact, including alkaline phosphatase may be a much more sensitive measurement. As serum alkaline phosphatase is a good marker of bone mineralization, but also of the actual total bone turnover. So it's a very useful additional marker. There are lots of other recent investigations coming up in terms of how one can assess bone turnover, even from DEXA scans, and including the composite unit of muscle and bone rather than only the bone. So lots of things in the pipeline.
And one last one from myself. So I've read the article, and it's recommended that if you use a dialysate calcium between 1.25 to 1.5, that's something for the adults actually. Is it also the same for kids?
Yes, usually there are a couple of rare, not rare, specific situations. Infants often need a much higher calcium intake, and children on long dialysis, such as nocturnal or daily dialysis, may require higher calcium intakes. So this is really important. And in these particular groups of patients, specific groups, we would use dialysate calcium of 1.75 millimoles per liter.
Mm-hmm.
So I have, I think, 3 or 4 final questions. The first ones are all on nutrition again. I guess all of you see a rising number of parents who aim to raise their children with a vegan diet. So what do you recommend these parents when they come with children who have CKD?
Very good point and a really topical issue. So vegan diets in the growing child are really not recommended. They need calcium, and actually a growing bone needs calcium and phosphate in healthy children to form hydroxyapatite for the bone mineral. So we do not recommend a vegan diet. We try and convince these families that a vegetarian diet is perfectly reasonable, and there's nothing wrong with that at all. And in fact, many benefits in CKD with a plant-based diet, but going vegan in a growing person is not a good idea.
Because of lack of phosphorus then, because you could say, well, one could add calcium via supplementation, but this would mainly be caused by this lack of or low phosphorus in the diet then?
Indeed, you'd have to give a lot of supplements, calcium and phosphate, both being really important if somebody was on a vegan diet. So if some family absolutely insists on it, then we have to provide the supplementation.
And then I was surprised to see that about 27%, I guess, of all calcium intake is by cereals. So does this refer to the UK, where you have fortification of your diet with calcium, or is this really in the cereal itself?
No, it's for everywhere in the world. And I also, my dietitians educated me on this. So cereal does not mean your Kellogg's cornflakes, yeah, which you have for breakfast. Cereals means grains. So any grain which you can have in bread, even in your nutrition, in your grains, that's what cereals mean. I was also caught out by that.
Thank you. And are there any websites that are available for doctors, maybe even for patients, that you would recommend? Because again, surely none of you people has the time to go through the diet each day, where people can really study their calcium intake at home, or would you rather recommend specific programs that have to be bought before?
This is such a good question. There are no programs for children, no endorsed programs for children. There are very good programs for adults, which can be national level programs, as well as the Osteoporosis Society, where you have free online calculators, which are really very good. For children, we don't have that. And yeah, something definitely to look into, though, for the future.
My last question is, I guess, the most difficult one for everybody. What about vitamin D? Because surely calcium uptake depends upon vitamin D. And in adult medicine, we have actually reduced quite substantially the prescription of active vitamin D. And here in my clinic, I always ask the young doctors, why do you give vitamin D to your patient? I really try to avoid it as far as possible. But again, surely children are different.
I think, again, another excellent question from yourself. So I just kept this in reserve. So if you look at the table on the right-hand side, the 25-hydroxyvitamin D levels, as you see them going from extremely low at less than 10 to more than 250, are really physiologically associated with rickets or osteomalacia and the extremely low levels, then a stimulation of PTH, and a reduction in calcium absorption if the level is low, between 10 and 30, and then some variations and a mildly raised PTH. And then, of course, at higher levels, you have excellent calcium absorption with a very wide therapeutic window before there's a risk of hypercalcemia at levels more than 250 nanomoles per liter. And with this in mind, in the children, we suggest that we keep serum 25-hydroxyvitamin D levels above 75 nanomoles per liter, which is equivalent to 30 nanograms per mil. In CKD 2 to 5 on dialysis, we've defined sufficiency, insufficiency, deficiency, and severe deficiency here. And we suggest that the monitoring is no more than 3 monthly. And we aim for levels in this range of 75 to 120 nanomoles per liter. So this is a recommendation we produced about 7-8 years ago from the ESPN, European Society for Paediatric Nephrology, and the EUROD group we are now together working on vitamin D guidelines, which we hope will be prepared by the latter part of the year. Thank you.
This was not pre-planned, and thanks so much for this clarification. So it's all about native vitamin D, actually. You would not really go for active vitamin D. You measure surely native vitamin D levels, and
Yes.
you also supplement native
Correct.
vitamin D.
With cholecalciferol. The children, the patients, all patients with more advanced CKD are unable to perform that 1-alpha hydroxylase step in the kidneys, and therefore need active vitamin D as well in the form of alpha calcitol or cholecalciferol. No, so that's not alpha calcitol or calcitriol, sorry. And that may also be needed in patients with more advanced CKD and on dialysis.
I guess this was a great cliffhanger to maybe another talk on vitamin D as soon as your next recommendations will be available. Until then, thanks so much. This was really brilliant and a really pleasure for Andreas and me. We were kind of anxious to dive into pediatric nephrology. Thanks to Lars Faber, we had great support. Thanks
Thank
again.
you very much for inviting me. Yeah.
Hoping to see you back then in the second part of this year. Thank you.
Thank you. Children are not so scary. Don't worry. Thank you.
Well, my wife is a pediatrician, and she's my greatest critic. Hey.
Thank you very much. Nice to be here, and thank you all for this opportunity.